I'm Dr. Forrest Tennant, and I was pleased to give the pharmacogenetics lecture to the conference on pain care and primary care. The first point that I want to make to primary care physicians is exactly what is being tested when the term pharmacokinetic or pharmacogenetic testing is used. The testing is not normal to what physicians do. We physicians are used to measuring things in numbers. Now, in pharmacogenetic testing, it is not specific. We're actually measuring activity, and that's quite vague compared to a number. Now, the activity is in about 4 different categories. And now, the main one is enzyme activity. Some of those go under the name cytochrome P450, and others go under names such as catecholamine, catechol methyltransferase, and these are enzymes and their activity. We're also measuring activity with what they call receptor binding, meaning how well does a drug attach to the receptor where it's trying to create an activity. And we have a new kid on the block called measuring the activity of transporters. Now, these are protein substances in the central nervous system that transport neurotransmitters. And we now have the technology to measure this activity. Now, what is important about this is that, number one, the physician needs to know what he's measuring. Which ones of these things are being measured? Now, the second thing that I want to call to the doctor's attention is this: who should be tested? Well, there are some definite indications to use the pharmacogenetic testing. The number one reason you use pharmacogenetic testing is in a patient who is not doing well with standard treatment. In other words, the patient just isn't making it. They're not responding to the treatments that the doctor is giving. And so you're going to take this test to get a clue as to how to change that therapy. Now, a couple of categories fall into that. Those patients who need high opioid dosages, such as those who exceed the CDC guidelines, which is 90 milligrams of morphine equivalent a day, all those people have an indication to be tested. Patients who have genetic diseases, for example, sickle cell disease, Marfan syndrome, Ehlers-Danlos syndrome, these patients have a genetic disease that's known to have defects, and they can be tested. Now, the third issue is how much testing, or even should a primary care physician start doing pharmacogenetic testing? And the answer is yes or no. It's not solid. It depends on the physician's practice, how much time they have to learn about this, how serious are their cases. There's a lot of factors that go into this. But I want to make one thing abundantly clear. No physician should feel compelled to rush into this.